thought it was like, well, we have
It's an LLC.
Oh, okay.
Like a bunch of bar foods. I mean, well, I mean, it's good food, but it's still food, you know, so I feel like it's
Okay, so I was gonna just try to keep the show going here.
Yeah, but this is one really just patented. This is a kid because
What magazine is that?
Bloomberg.
misinterpretation of the text and one being
I'm sitting, so, yes, wine, let's change it up.
Is that generic or is that related to us?
No, it's generic. But I think it's important to know that this is, people are talking about it on a regular basis. I was going to use it to explain the next generation sequencing versus the old school. Okay, so this is Bloomberg, and I guess it's this month, but there's an article, a whole article that said, would you pay $1,000 to find out how you might die? And it's by a manufacturer of someone that does genetic sequencing. So Illumina sells the equipment to all the manufacturers, or to the labs, I should say. And you can see the stocks just going up through the roof since 2004. And what they're showing here is actually the older school technology. One thing about AI biotech is we use what's called next generation sequencing. Our competitors are using these older school platforms where they'll have a tray and there'll be 96 different places where you can put information, and they put it into like a big microwave looking type thing, and it's not as accurate and it's slower. It doesn't look at the genes as many times. Where with AI biotech we use what's called next generation sequencing, and when we sequence someone's swab, we look at the gene over 200,000 times, and we have about a 99.7% accuracy rate from the time the swab comes in that we will get the correct information to the physician. So AI Biotech is going to publish a paper with next generation sequencing. No one is even as close to being where we are. We put all the information on a computer chip. It gets stored in this mega $5 million computer. And what we're able to do is, Larry was saying, make sure we talk about ethnicity. Well, people's race, is very important in genetics. Whether it be Asian or African American, Caucasian, or Latino. What AI Biotech is going to publish is all the various metabolizer statuses on the people with different races and every single gene that we sequence. So this will be, state-of-the-art, huge number publication that we will be proud to say that it came from our lab. So there's 3 physicians in here. This is a presentation that I put together for pain, since there's people that prescribe a lot of pain medication, and we'll start with this. So what we sell is personalized medicine. So the whole thing behind genetic testing is that one size does not fit all. What we are able to do is identify people's metabolizer status. So we're going to look at 5 genes that metabolize about 75% of the medications prescribed today. And actually, this is outdated. There's actually over 100 medications on the market now that have black box label warnings, and they range from codeine to Coumadin, Plavix, Coreg, and Valium. So they're very commonly used medications, not like these some odd medications that no one's ever heard of. One gene in particular, 2D6, metabolizes roughly 30% of all the medications, and a bulk of your opiates go through 2D6. And pharmacogenetic testing is now standard of care at places like Harvard, Mayo Clinic, Vanderbilt, Scripps, Columbia, and now University of Florida. This is, when I sit down with a physician, and Tammy can testify to this as well, if she were here today. We just saw a physician, Dr. Perry, and all I did is I sat down with the physician and I said, with just this slide up, okay? And this is what helps the physicians have their aha moment. So, you know, fortunately, you know, Tammy's, John is a financial planner, and so when I say to the physician, I said, look, if your financial planner could avoid all your poor investments before you choose a stock or an investment, would you like your financial advisor to use it? Absolutely. Well, that's all genetic testing does for you as a physician. So you have all the patients that you're going to see today, and through genetics, we're going to find out that the bulk of them are going to be, you know, typical. And that kind of goes along with the Eric Topol statistics I showed you earlier, where there's about 41 out of the 475 that were at high risk due to their genetic makeup. All of your patients actually will be normal, but you're going to have your patients that you're going to know in advance that they're not going to respond to medication, or they're going to be, needing to have their medication altered, either lower or higher based off their metabolizer status. And so it allows you to practice medicine with more precision. So as opposed to, here's your 50 Aloratab and we'll see how you do, we can now say, based off your metabolizer status, you're one of the 2 or 10% of the population that won't respond to Loratab. So we actually have to go through a different pathway, like methadone or fentanyl, through a different pathway to get proper results for you. Or you're one of the population that either processes the medication too slow or too fast, and so we can use the Loratab. We just need to either increase or decrease the initial dosage to have the desired effect that we need. And here's the current practice. Everyone's getting knee surgery or spine surgery. You have your standard order. Rob, what do you use for pain?
It's variable. I'm a PCA guy, but the thing I like, I've switched over to a lot now, is IV Tylenol.
Yeah.
To get away from the opiates and the narcotics,
Yeah.
side effects.
Exactly. Dr. Tu, how about yourself?
Morphine and Dilaudid are pretty much
Okay.
what we use in the ER all the time.
Yeah.
Toradol as well too, all the time. And,
All right. So, but for a lot of the surgeons out there, they're using the hydrocodone, Loratab, etc. So they have their standard order. So everybody in this room, if we're going to get our knee or back or spine operated on by a particular doctor, standing order. Well, now, based off your metabolizer status, we can say, look, this person only needs half the normal dosage. This person needs probably, an increased dosage and almost 2 to 3 times the normal dosage if you're an ultra-rapid metabolizer, where you're just going to burn through the medication very quickly. And so what we did is we actually have a link that I showed you earlier to the website. I've got a guy, Chaz, updating this list now, and it will be updated on the website probably hopefully by tomorrow. But the 2D6 pathway, here are all the medications listed by the FDA that have genetic warning labels on them. And they're not, like I said, these, there's Coreg, one of the most commonly used beta blockers. Abilify is a psych drug. You have Celexa, Lopressor, Paxil, Rhythmol. A lot of the EPs use that for rate control on AFib. Pamelor, Luvox, Prozac, codeine, quinidine, very commonly used medications. And then 2C19, there's a list of those. And a lot of the physicians, does anyone know, maybe other than Dr. Saha, because he may have been here last time, remember this, do you know why you can't mix Plavix and Nexium together? they're both going through the 2C19 pathway, okay? So here's Plavix, and it's at, and so when you put Nexium, two large vehicles going down one pathway, so they slow them up. And so you don't get the desired effect, from the Plavix that you need, and so that's why they don't want you mixing Nexium with that. And I actually had the same thing with my son who was put on Onfi. I have a son that takes Nexium, and they put him on Onfi to help his movement disorder. And he started having all these adverse drug reactions. He was like gagging and vomiting and things like that. And I had to send my pediatric neurologist all this information before she finally, okay, I'll get him off Nexium, and we got to find a different proton pump inhibitor. And we ended up going to Prevacid, which actually took a little while to figure out that most of these proton pump inhibitors are going through 2C19, but Pepsid actually went down a different pathway. We put him on Pepsid, all the adverse drug reactions started going away, and he got back to being normal. So he actually responds better to Onfi than he was with the gabapentin that she was using previously. So at the end of the day, we're better off. But way medicine's practiced now is you start, if you're on Nexium, you start on a different drug, you get an adverse drug reaction, what do? You take that drug away, right? So what we want to do is just shed some light on these different pathways to the physicians. And as representatives of the company, when you start telling the physicians, things, bringing things to their attention, they'll sit there and say, hey, thank you. These are the things that I need to know as a physician, so that I can start practicing medicine to the best of my ability. I mean, you're practicing, but you're using technology today that's available to help you make these adjustments. So this is from the director of the Office of Clinical Pharmacology at the FDA. And it says, what we learned about this trial and error approach leads to greater patient dissatisfaction, poor clinical outcomes, and greater expense, especially for chronic disease. But in many situations, the empirical approach is the best approach we have. Personalized medicine, which is what we sell, aims to streamline the clinical decision by using biological information available through a genetic test or biomarker, and saying, so based off your profile, I think you're more likely to respond to drug A or drug B, and less likely to have a adverse reaction with drug C. So the idea is to get them on the right medication, get them on there sooner. So I come in as an emergency room patient to Dr. Tu. I've got a problem. He has to start prescribing medication. Think how much easier his life is going to be if you actually have your metabolizer stats out there. And he needs to make quick decisions, okay? And time is of the essence in certain situations. So if he can sit there and now say, okay, here, look, you're not going to, no matter what I give you through 2D6, it's not going to work, So I need to go through a different pathway, or I need to just get you on a higher or lower dose from the beginning. AMA, very similar statement. Advances in personalized medicine rely on the knowledge of the patient's genotype influences his phenotype, which is the alleles that I don't want to get too technical, but using the principles of personalized medicine, healthcare providers may be better equipped to move beyond the one-size-fits-all that defined much of patient care in the past that is appropriate for the unique patient subgroups. Okay, so once again, I'm a surgeon.